a feast. One of them will be a musical feast, which you will hear at the beginning, and then we'll get to the real crux of the matter when we talk about heart health. So I am particularly pleased to welcome the team that has come from RWJ Barnabas Medical Center. We truly appreciate you for making the trip. It is said that if music be the food of love, play on, and the Altino brothers, a world-renowned pair of organists, and their musical friends will be treating us to a musical feast, a short musical feast before we get to the meat and potatoes, you might say, or as we would say, the plant-based meat and potatoes. So it is a joy to have you here. We are looking forward to what we will receive from everyone who presents, from the beautiful music that leads out, and we pray that you will all be blessed by what you experience this evening. Everyone, welcome.
Let us stand as we pray together. Shall we stand? Almighty God, we want to thank you for the blessings of this day, all of this day that we have enjoyed so far. We want to thank you for this wonderful program put together to educate us, to inspire us, to inform us how we can better take care of our heart health and live healthier, longer, happier, wholesome lives here on this earth as we get ready to be with you in your kingdom for eternity. May your presence be felt in this place. Bless everyone that will present and those of us who will listen both in the house and virtually. May we be edified through all that shall be said and done this afternoon. Thank you for the organizers. We thank you for placing in their hearts the desire to put this program together. May you glorify your name through it and just bless all of us as we engage in this informative program, we pray. In Jesus' name, amen. The Altino brothers.
Brooklyn and the city of New York, welcome to the Hanson Place Church, a New York City landmark, a citadel of hope, of worship and community service. Today we welcome all of you from the virtual platform, on the virtual platform, and for the members of the Hanson Place Church, all the official representatives from the city of New York, attendees here from the Fort Greene community at large, and the wider viewership nationally and internationally. We recognize in our midst some of the brightest minds and skilled clinicians from the R.W.J. Barnard's Health System, and Dr. Ella Jean Richards-Francois to lead a conversation on prevention, intervention, and cure. Heart disease is on the rise, and as you know, it's the #1 leading cause of death in these United States. And today, more than ever before, we understand the value of prevention. Treating heart disease is expensive, but adopting heart-healthy habits may not only save your money, may also save your life. And so today, we are happy to have in our midst all these professionals who specialize in the field of primary care, critical care, transplant, surgery, cardiologists who can answer your questions. And those of you who are online, you can text your question to us. And after the presentations, we will have time for a Q&A. In our midst this evening is Dr. Elagine Francois. She's going to be first up. We are happy to have her in our midst. She's right here from the Hanson Place Church. Put your hands together. Dr. Francois comes with a very, very long resume. Still a graduate from the University of Connecticut School of Medicine. And she's here today to present. You see, she deals with our children. And we know that it's one thing to take care of heart conditions when you're 70, but the true prevention starts when you're young. And so please welcome Dr. Elagine Francois to the podium.
Can you hear me? All right, wonderful. I'm not the type of person to stand still, so I walk around a bit. And luckily I'm short, so I won't get in your way. So welcome. I would like to welcome my colleagues in medicine, fellow physicians. This is my church. This is what raised me. This is where it nurtured me. Very happy to have you here presenting to our congregation. To my congregation, I love you guys. I never left my community because of you. I felt that my community needed a physician who understood and cared. My patients deserve the type of care that I give them. And I train residents and medical students to also give that type of care. And let me tell you something, they love working with our community because they find that there's a place that they can actually make a change. We respect medicine, we respect science, we respect them when we come into their presence. That's not the case with every community, okay? So they love serving us, and we want you to come and ask questions and be informed when you come so that we can make the best difference, okay? So I don't know how many of you remember in the 70s, Candy Stanton had a nice song called Young Hearts Run Free, okay? But not for long. See this tired heart? Okay. So there's heart disease is two types, congenital and acquired. Congenital is what you're born with, acquired is what you get over time. And there's many different types of congenital heart disease. The heart has a lot of changes that it has to make in that transition from fetal life to adult life, and sometimes those changes don't happen the way they're supposed to, or the heart is malformed from in utero. And so sometimes these things come up right away. We notice it in the nursery, but sometimes you don't find out until a patient is much older. And they've had this all along, and no one knew. Unfortunately, we're not really talking about congenital today because we're talking about things that we can prevent, right? And that's not one of the things we can prevent. We can prevent acquired heart disease, okay? So that's what we're gonna spend our time on today. Acquired develops later in life. It affects, when we say the heart, we don't mean just the muscle of the heart. We mean its vessels, its valves, any damage that can come. And that can happen by disease, by infection, lifestyle choices, which I'll spend a good amount of time on today, and trauma. Everybody remembers when Damar Hamlin went down, right? So things like trauma can definitely affect your heart. Okay. So when we talk about preventing heart disease, we have some things that are diet and exercise related, but there's some things that are not. If you see at the top, there's smoking, okay, and toxic stress. So one of the things they asked me to talk to you about today was mental health and how that affects your heart. So we're gonna spend some time on that. Smoking, although preventable, is not related to diet. We'll agree? Okay, but look at all these other things that are related to diet, okay? Your weight, having an unhealthy diet. So you could be skinny and unhealthy, right? It's not everybody who's skinny is healthy, and everybody who seems overweight is unhealthy, okay? So just even what you're eating, what you're choosing to eat. Physical inactivity, so just getting up and getting a little exercise. 30 minutes a day, and it doesn't have to be 30 minutes altogether. It could be 10, 5 days a week, okay? High blood pressure, Okay, that's what hypertension is. Dyslipidemia, these are your cholesterol. When they say know your numbers, know your cholesterol numbers, triglycerides. So having those out of sync will also affect your heart. Diabetes. Diabetes causes high what? Sugar. So what that does is it damages tiny little vessels, okay? You have tiny little vessels in every organ that serves your body, all right? When you go to the doctor, make sure they're looking in your eye, because that's where we can see those tiny vessels. When I'm looking in the back of your eye, I'm looking at your kidneys. I'm looking at your liver. I'm looking at everywhere else that we can't see without some type of invasive procedure. Looking in the back of the eye is very simple. Dental disease. A lot of people don't think about it, but when it's not just, what damages the vessels is inflammation. So having states of high inflammation are gonna make you have more damage. And things that you forget, you neglect, like your dental health, can put you in states of high inflammation and then cause stress and damage to the heart. Okay, so diet-associated disease. We got a nice yummy, the kids will know, right, Justin? Justin's up in the top, this is what he wants to go get. I've learned all of the different, I don't even know what to order when I go, but I learned there's a 4x4. 4 for 4? Does it say 4 for 4? I have to learn from my patients how to order these things. My kids were like 4 and 5 years old. They didn't know. They said, Mommy, do you know that there's a place, Ryan said to me, there's a place with a big M on it, and they sell hamburgers. And I said, really? Really? I didn't know about that. He goes, if you go there, you might find it. And I said, how did you find out about that? Yeah, she's turning her head, because TT took him there. My kids never knew about McDonald's until TT took them there. So a little bit, everything in moderation, right? Even moderation, okay? So yes, you can indulge, but when this becomes your type of diet, now you're putting yourself at risk for what we talked about, obesity. That big chugging soda, okay? The sweetened drinks puts you at risk for dental disease, okay? And we talked about what damage that can do. It will lead you to hypertension and diabetes type 2. Okay, so let's start at the beginning. So where's the beginning? Your first food, okay? We always say breast is best, but why is it the best, okay? There is actually now, before, when women were entering the workforce, World War II, all the babies came off the breast so that they could be managed by somebody else and the woman could enter the workforce, okay? Now, luckily that pendulum is swinging back where women are beginning again to be the first source of food for their babies, okay? So when you have this long gap, you don't have a lot of current data about the benefits of breastfeeding, okay? And then also you have to look at the population you're studying. If you're not studying our population and you don't know what our numbers are, you're kind of guessing what they are based on the data of the population you do have. But now that evidence is coming out, we're seeing that there's moderate evidence to show protection against type 1 diabetes. That's not even type 2. Type 1 is an autoimmune disease. This is the one that kids get. However, just a little caveat, breastfeeding can increase the risk of dental caries. Dental caries is dental disease after age 1, okay? And that's because anything put in the mouth without washing it out can damage your teeth, okay? So think about all those women who were, I remember when I was breastfeeding, my children fed themselves. I was asleep, right? So you have to create some separation sometimes, wear some zipped up clothes, okay? So the kids can't get to it because nobody's brushing teeth 4 a.m. Kids shouldn't be eating 4 a.m., okay? So we should be stopping that early enough before the teeth come to prepare for good teeth coming in, okay? So it's not that breast is not good, it's just that, again, everything in moderation at the right time. There is limited evidence so far to show that breastfeeding protects against obesity, okay? And this protection is found especially in white children, again, because this is where most of the data is obtained, okay? And also, if you look here, this was not shown in Black or Hispanic children because there was confounding variables of socioeconomic status, meaning that they could not separate what was due to stress from poverty and what was due to actual protection from breastfeeding, okay? And that's why we're gonna talk later on about stress. Okay, so what we do as pediatricians is we monitor growth over time. Every time your child comes to the doctor, they get a dot on his chart. That means if you don't come, you don't get a dot, okay? Or you get some dots that are far apart and it's not the best, okay? Every time you look at a chart, you need to know what's on the y-axis and what's on the x-axis. And I know you can't see it because it's a little small, but on the x-axis is the years of age, and on the y-axis is the weight. And you will see that the weight goes up over time. Of course, we all know that. You know, babies are born at one weight, and then by the time they're 10, 11, 12, they're another weight. No big deal. But how do they grow? Okay? How do they grow? In the beginning, you see the slope of this line, right? Early on, they're feeding frequently. How often do babies feed? Every 3 hours if they're on a bottle, getting formula. Every 1.5 to 2 if they're breastfeeding. Because formula is cow's milk or soy milk. And it takes longer to digest. So it sits like a little brick in the stomach and doesn't digest. And the baby stays asleep and mommy's happy, but it's not good for baby. Breast milk is rapidly absorbed. Sometimes those babies don't even stool for a while because there's no waste. And then they get hungry again very quickly because they need the next feed. And so their feeds happen more often, every 1.5 to 2 hours. Parents get used to this pattern. Baby's eating all the time, and they take pride in it. Oh, my milk is good. Ooh, the baby's eating well. Ooh, this good baby's going to be healthy. And then they turn a year old, and it slows down. And they go, oh, my goodness. And even worse, the grandmother comes over. I'm getting mager, okay? And they worry, and they say, the baby is not thriving because they're not eating. I put the food in, the baby's not eating the food. But what's happening to the baby? The baby's now growing at this rate. You see the difference? You can't eat like this when you're growing like that. And this is another reason why breast milk helps. Because when you have the baby attached to your breast, you have no control. This is what causes a lot of stress for my mothers, is they have no control of how much the baby gets, and they want control. They wish they had the little hatch marks on their breast, 4 ounces, 3 ounces, 2 ounces, and they don't, right? So they can't tell, okay? And that lack of control gives them a lot of anxiety. But it's better not to have control, because when we have control, we mess things up, okay? The baby is allowed to take what they need, come off the breast when they're full, and mommy's happy. Baby's full, I'm free, I can go do something I want to do, right? With a bottle, you have a little bit left behind, what do? You encourage it. Man, I made the son came out of bed. You're not going to just leave this little bit here, just take a little bit more. That little bit more overrides the baby's satiety center, located in the thalamus. It tells you you've eaten enough. You keep overriding it, you wind up with a person, listen, if you hear something that's familiar, who doesn't know if they're hungry or not, okay? They just eat because food looks good, food is there, but they don't know if they're hungry or not. They eat, and next thing you know, they're overstuffed, and they don't know how they got overstuffed because they don't know how to stop, okay? So it's very important when the children slow down their feeding to allow them to. Lincoln, you can't hold up your hand and tell me 5 minutes because you gave me a list of things that cover. All right. So now this is what we do. We're watching the BMI. The little cartoon says, don't step on it, it'll make you cry, okay? So I want you to look at this line here. What do you notice about all these lines? On this is the y-axis. This is your weight in kilograms, meters squared. So that's the body mass index. That's how we calculate it, okay? This tells you if you're overweight, normal weight, overweight, okay? This here, again, is the years in age. What are you noticing about the first part of this graph? The lines are all going in which direction? Down. That means the body mass index is going down. What makes the body mass index go down is you are gaining in height while you're not gaining in weight. So those kids are coming long and thin. They don't start regaining weight again until after age 6, okay? So some of our kids do keep eating like newborns, okay? And they're coming in these little plump, chubby babies, and we know by looking at them, but you don't realize that they're already at risk, okay? And you should see, in a child who's 2 and above, you should always see their ribs. If they raise their hands over their head, you should be able to count 3 ribs. If you can't count 3 ribs, you put it on too much weight. Now you have some kids who will eat a lot and then shoot up in growth. That's okay. They put on the weight, and the next thing you know, boom, you're buying clothes, you're buying shoes, because everything is growing. Okay, so now this, I brought actual patient data here for you to see, so you can see some of what happens. So we know the BMI chart again. This is the BMI on the y-axis. This is the years on the x. What do you notice about this patient? Where did their BMI start out? Normal or not normal? So normal is around this black line, but you can choose any of these lines, honestly, if you stay with it. Okay? So here they are. Most of their dots are here. Okay? They had a few dots there. And then you can see this black line going up like this, right? But you see this patient's dots, are they going up like the black line is going up? No, they're going up much quicker. So I'm going to tell you about this patient. This is a patient with a family history of morbid obesity, meaning the parents are morbidly obese, everybody in the family is morbidly obese. And this baby started off looking low, underweight. And what do you think they said? Yeah, Imaga, we got to feed him. So they fed him, and they fed him, and they fed him, and they fed him, and they fed him. Okay? So we have to always educate our parents not to do this to the children. Okay, here's another one. This one was normal weight initially. Everything was going well. And then something happened 2 years ago. What do you think happened 2 years ago? COVID. Not going out to play. Having food available all the time. Being bored, okay? And then also he had some familial stress, okay, going on. And this is what's happening. So we're trying to bring this under control, and you can see very clearly, well, not very clearly, that there's a dot up here, and we succeeded in bringing his body mass index down a little bit in the last visit. Okay, so preventative measures. Pediatrics is the study of how to prevent disease. That's why I love it. It's not catching the people once they're already in the water drowning. It's stopping them from getting into the water in the first place. We need to closely monitor weight gain and make adjustments when necessary. It involves the entire family, okay? So very often I'll send the family out to do some measures. I know it's working. When they come back in and everybody's looking thinner, all right? We avoid sweet juices. Remember, we're not just worried about the sugar in our bodies, we're also worried about the sugar in our teeth. Avoid sweetened cereals, okay? Avoid the use of high-fat dairy after the age of 2. So nobody in their refrigerator should have whole milk unless you're dealing with a child under 2, okay? Discontinue bottle use at 12 months and avoid nighttime breast or bottle use after the age of 4 to 6 months. These babies should be sleeping through the night. Recommend, like I said, the aerobic exercise, 30 minutes, 5 days a week at least, that's the minimum. And avoid exposure to first, second, and third-hand smoke. You all heard about third-hand smoke? Okay, what's first-hand smoke? You smoking, okay. You blow it out because you're so kind, the rest of us can breathe it in. Thank you. Second-hand smoke is when we breathe it in. Third-hand smoke is actual particles. And when you come and you sit down or you touch something, you leave those particles behind. And people will come behind and pick them up, just like COVID, and then their asthma gets triggered. Their, whatever else is caused by exposure to smoke gets triggered, allergies get triggered. So third-hand smoke exposure is something to also worry about. Vaccinations, including COVID, because we don't know, I think I turned something off. We don't know what damage COVID is doing to our hearts. Okay, so try to minimize getting it. I've had it, okay? And try to minimize getting it. All right, so weight management over time. This slide is just to show you that for girls start menstruating, they have about 2 more years to grow after that, okay? When a child is still growing, all of them stop, boys and girls stop. When they stop, we can no longer manage their BMI with them growing, okay? So it's a different weight management strategy before they stop growing and after. Before they stop growing, it's really not recommended that you ask a child to lose weight, depending on where they are in their curves, okay? If there's a chance that they could grow into the weight, the goals really are to maintain the weight they have. Because over time, that's the same thing as losing weight. But once they reach this flat part of the curve where all the adults are, like I keep threatening Justin I'm gonna grow taller to meet him, but it's not gonna happen. The only way I can decrease my BMI is by losing weight, okay? Early detection is the key to prevent disease. So we try to pick up early on children who are at risk. We can find plaques in children as young as age 2. And they say by age 10, all children have some form of atherosclerotic disease. So we pick up early on those abnormal BMI trends. So don't look side-eye at your doctor, because I know you all do this. You do this to me all the time. Don't look side-eye when the doctor says they're gaining weight too fast. This is why they're saying it, okay? Pre-diabetes and diabetes. Pre-diabetes reversible. Diabetes, they'll call you in remission if you get it under control, but they're not really thinking that you're cured, okay? So you want to catch people before they get into pre-diabetes, but once you get into pre-diabetes, then you need to really watch, okay? And noticing signs of body stress. I can see, and I explain to the parents, I say, that darkness on their neck, all of these lines that you see here, this is the body tries really hard not to fail you. It tries really hard, okay? We put things in and we damage our bodies all the time. And the body tries really hard not to fail. But you could see the signs of stress that the body is beginning to lose the battle. Okay, so pay attention to those early signs. All right, so here is the toxic effect of stress, the effect of toxic stress on an adolescent that I had. I started taking care of her here. And just to give you a little thing, this is the BMI again, this is the age in years. This is the top of the normal curve. So we can see where this child is, way out in the sky, very, very obese, okay? When I look back into her chart, the reason why it didn't come out right away, because taking care of her now, she's much older than this, she was molested at camp here, okay? And from the time of her molestation, her weight skyrocketed. You're not gonna manage this with diet and exercise. You have to manage this with intense counseling, medication, and alternative therapies. All right, so what about stress? So we have positive stress. Positive stress is what we all felt when we were trying to get here and, look for parking, right? when you learn a new task, that can be stressful, right? All the kids in school, right, learning in school, that's considered positive, okay? Once you overcome it, you actually feel a sense of increased self-esteem. It's actually good for you. It helps you to grow, all right? There's mild elevations in the stress hormone levels, but they return back to normal. This is what's necessary for you to grow, okay? Then you have tolerable stress, okay? This would be like a parent dying or getting a divorce. That's not positive, okay? But you have good support system around you. Okay, a child in this situation can't choose the life they're born into, but they have good support structure around them. So it gives them elevation in their stress response, but then with the support, with time, their stress hormone levels go back down to normal. Toxic stress, on the other hand, this is the prolonged activation of the stress response systems in the absence of protective relationships. This is where a lot of my patients lie. This is where that girl we talked about lies, in toxic stress situations. When you have parents that can't find work continually, when you have them living in a place that's violent, they can't even go outside to play because they might get shot. That's toxic stress that doesn't go away. Those prolonged stress levels damage your body. In fact, it's even worse than that. So that was the good news. The bad news is toxic stress gets written into your genome. Once it gets written into your genes, it becomes heritable, meaning you can pass it to your children. 400 years of slavery has damaged people. Okay? This cannot be taken care of. We can try to help it out with counseling, but this here takes legislative changes and restructuring of our financial structure. Okay, that's beyond the medical world. We can put our part out and say, these are the changes that need to be made, but that's not under our control. That's under our control. Do you understand? Okay, so toxic stress, this is basically what I said. Okay? All right. The approach to heart disease prevention must be multifactorial because, as you see, the problems are multifactorial, okay? So prevention of dental disease and obesity, close management of growth and intervention when you need to intervene, education on proper diet, exercise recommendations. Mental health care is essential to deal with stress and to develop new habits. It's kind of hard to tell somebody, just change everything you do and just do it. They need help, they need direction, they need guidance, they need support. Improving the access to healthy foods. We need to address social issues that cause toxic stress and early detection of the disease when it starts. So thank you very much.
Come on, give her a better round of applause. That was definitely a comprehensive take on prevention from the baby up to adolescents or young adult, whatever it is. But you know, so when the primary care doc has done everything he or she can do to keep you on the right track, and things are really not going the right way, or just to maintain and to keep your heart in good condition, she refers you, or he or she refers you to the cardiologist. And the cardiologist's job is to care for the heart that is entrusted to his keeping. On our program, and well publicized, as Dr. Hake was to be our facilitator as a cardiologist, but just like a normal human being, is not well today. And so guess what? We have the best stand-in that is possible from our clinical staff. Dr. Braverman, he's going to come right up, and he's going to do Dr. Hake's presentation.
Good evening. So I'm stressed because I've never seen this presentation. It's tolerable, though. It's tolerable. So Dr. Hake is a interventional cardiologist. I'm Dr. Braverman. I am a critical care doctor, a cardiac anesthesiologist, and chairman of the Department of Anesthesia at Cooperman-Barnabas Medical Center. Dr. Hake was going to talk about a transcatheter aortic valve replacement, 20 years in the making. What is a transcatheter aortic valve replacement? Well, as my prior colleague mentioned, there are some things that are acquired and there are some things that are congenital. And we have the aortic valve is one of the valves in the heart, and some people, that valve narrows because they have a congenital issue, and sometimes it just narrows because we get older and it gets calcified and the aortic valve doesn't work as well as it should. So historically, the way to fix that, there was no medicine to fix aortic stenosis. We would do open heart surgery on these patients, which meant cracking the chest and a very big invasive surgery, which my colleagues will speak about in a few minutes, because there's other things that we can't fix with a transcatheter. But now we've developed a way to fix the aortic valve with a catheter through the groin. This has started about 20 years ago when we started developing these therapies to treat coronary artery disease through catheters in the groin. We then started to develop the idea, well, can we do more than just treat coronary artery disease? Can we treat valvular disease along with that? And at first, it was developed by a Dr. Alain Cribière in France, where he took a balloon across the aortic valve that was stenotic and just expanded the balloon and opened up the aortic valve, and it allowed the blood to pass through the valve easier. And this is still used today in certain patients, and it definitely can prolong the life in someone who is critically ill, but it's not a permanent solution. So then we moved from that to working with some other doctors and some very smart scientists at J&J and at Edwards, and they developed what's called a TAVR, which is a transcatheter aortic valve, and that started about 20 years ago. And what happens is that we actually stick a catheter in the groin, thread it up into the heart. The valve is then expanded in the aortic valve with a balloon. The balloon is then deflated, and now you have a new aortic valve in place. The catheter is removed. It's all done through the groin under local anesthesia, and it's amazing that within hours after this procedure, the patients feel symptomatically better, and they typically go home the next day. And that's, I believe, all Dr. Hake had to give us today.
Thank you. Thank you. I'll introduce Dr. Braverman later on, but he was just filling in for Dr. Hake at this time. Next up is one of the sharpest minds that I've come across in recent times. You know, she's a graduate of the University of Medicine, in Arizona College of Medicine. She is a person who has done many volunteer work, community service, gone to soup kitchens and homeless shelters, and clinics and vaccinations and stuff. She's a real down-to-earth kind of doc who is just ready to jump in at any time. Now she was a past fellow in our cardiac surgery department. Now she's one of our attending, one of the most skilled surgeons that we have on our staff. Dr. Persida Jotar will make presentation. Put your hands together as she comes forward.
Thank you very much. Thank you. I don't know if it's your voice or the procedure, but TAVR just sounds so amazing all of a sudden. So my name is Persida Drotar. I'm one of the heart surgeons, and I love surgery, so I'll be talking about surgery. Do I have the clicker? Thank you. Thank you, Lincoln. It's an honor to be part of this, so thank you. I think this is wonderful. I love all the red here. It's very important. It's hugely important, and especially to bring attention to the fact that Heart Month and women's health and heart disease doesn't present in women always the same as you read in a textbook. It's not always chest pain, crushing chest pain radiating to the jaw or left arm. Sometimes in women, it's something as simple as nausea, so we tend to overlook it. So it's very, very important to bring attention to this. So thank you for doing this. But I will be talking about heart surgery. So, you know, going from prevention, sometimes there's things, despite everything you do, you still end up with severe heart disease that eventually gets you into a surgeon's office. The most commonly performed heart surgery is coronary artery bypass operation. I'll talk about that a little bit. And then there's a couple of other types of surgery that I'll be talking about. So a little bit about anatomy. As surgeons, we love anatomy. We like to understand the structure of what we're operating on so we can kind of come up with a plan of how to approach it. So the heart develops in utero. So during fetal life, the heart develops initially as a tube. Basically, you have blood flow going into this tube and coming out the other end. Eventually, this tube kind of elongates, and then it folds on itself, and then it kind of twists. And it's really amazing how you have this tube that eventually forms into a structure that has 4 chambers, that is beautifully coordinated. It's basically a muscle, but the muscle doesn't work unless, one, you give it blood supply, so you need oxygen to go to this muscle like any other organ, and 2, you need an electrical conduction that stimulates the muscle to contract in this beautifully choreographed dance that makes the chambers contract at different times to kind of move the blood forward. So essentially, the heart has 4 chambers. 2 chambers on the top, they're called atria. They're the chambers that receive the blood. Then the blood goes from the atria to the ventricles. From the ventricle on the right side, you go to the lung. From the ventricle on the left side, you go to the rest of the body. So 2 atria, 2 ventricles, and the valves are what separates the chambers. So the valves between the atria and ventricles are tricuspid and mitral. And the valves that separate the right ventricle from the lungs, it's the pulmonary valve. The valve that separates the left ventricle from the rest of the body is the aortic valve. What Dr. Braverman was talking about is the valve in the aortic position is the valve where you can put a catheter and deploy that TAVR valve. I'll talk a little bit about the great vessels, the aorta and the pulmonary artery briefly a little bit later. And last but not least, our coronary arteries. So like I said, like any other organ in the body, in order for it to survive, you need blood supply. Blood carries oxygen, so you need oxygen for any cell in the body to survive. The coronary arteries are the blood supply that give blood to the heart muscle itself. They're the first vessels that come off the aorta, which is the big blood vessel that comes out of the left ventricle. So coronary artery disease, so this is extremely common, and this is what we're trying to prevent by addressing diet, by addressing exercise. The most common risk factors, diabetes, high blood pressure, high cholesterol, family history, and smoking. So there are definitely some behaviors that we can modify to help prevent and or delay development of coronary artery disease. And like it was mentioned earlier, we can see plaque inside of the coronary arteries as early as like before puberty. Eventually with time, this plaque kind of tends to thicken, it can progress. Eventually it can completely occlude a vessel, or sometimes it can rupture. When it ruptures, the blood has not seen the inside of the blood vessel, so it develops a clot. That clot can block off that vessel and cause what we call a heart attack. So if you have no blood supply to the brain, that's a stroke. If you have no blood supply to the heart muscle, that's a heart attack. On the right side of the screen is basically transverse cross-sections of a blood vessel, looking at the artery wall and the plaque that kind of slowly gets thicker and thicker, and the picture on the bottom is where you have a clot that formed. So what happens in case of a roadblock? Basically, this is decreased blood supply to the heart muscle. So with time, if this plaque develops slowly over time, the body is amazing. We have different ways to compensate. So if it happens slowly over time, then the heart kind of tends to form collateral. So there's abnormal heart vessels that kind of form to reroute blood supply to the heart muscle. So we can see when we look at a coronary angiogram, which is a study that looks at the blood vessels of the heart itself, you can see all these extra vessels that are kind of trying to navigate and kind of get to give blood supply to the heart muscle. And that kind of gives you an idea that this is a process that's been going on for a long time. Now, that's one possibility. That doesn't always happen. Sometimes you just have no time to develop collaterals, and you just have complete blockage of an artery, in which case you can have a massive heart attack, and some people die from this as well. So what can we do? So from a surgical standpoint, when we have an area that's really, really narrow, and we can measure specifically how tight that vessel is, how big the plaque is, we can reroute the blood supply by doing an operation. It's called the coronary artery bypass surgery. So most common, people get 3 or 4 vessel bypass on average. But you can have something as low as just 1. So there's specific times when you can have, Dr. Braverman mentioned briefly the development of stents, how this started with the TAVR as well. So there's specific indications when you need to go to surgery versus when you can have a stent placed. So the stents are basically a way to open the vessel from the inside of the vessel. Basically, you put a wire through, and then you can put a balloon and open up that area, and then put a stent that keeps it open. And that has gone through several different progressions, because some stents can also close off, or they thicken over time, and you have to be on blood thinners as well. Now, when there are multiple areas that have blockages, or you have multiple areas or a large vessel in the setting of diabetes, those are specific indications when surgery is the preferred option. Reason being, when we look at studies, long-term studies, we notice that people tend to live longer and do better if you go that route. Now, sometimes because of anatomical reasons, it's difficult, too much calcium, so there's specific times when surgery is a better option or when percutaneous intervention with stent placement is the better option. Now, what do we use to actually reroute the blood supply? So when we talk about bypass surgery, CABG abbreviation, coronary artery bypass graft surgery, so we need some sort of conduit to reroute the blood supply. The most commonly used conduit, and it's the one that actually tends to stay open the longest, is the artery that comes off the left subclavian, the artery that goes to the arm. I can't point, right? Can I point with this? Oh, okay, sorry, thanks. So this blood vessel, so this is the aorta. This blood vessel is the subclavian, left subclavian. It's the vessel that goes to the left arm. Now, there's this tiny, tiny vessel that kind of runs down underneath the chest wall on each side. That's called the left and the right internal mammary artery. Lima, REMA, abbreviation. We like abbreviations in medicine. So the left internal mammary artery is the most commonly used conduit for bypass surgery. And it usually goes to the blood vessels that sit on top of the heart. The heart is kind of rotated and twisted to the left. So the top side of the heart is the right side. Left side tends to be a little bit further down. So we use the lima to that vessel, lima to the LAD, left anterior descending. That is the most important anastomosis. It tends to stay open the longest. Now, other options, arteries tend to do better than veins typically at staying open longer. There's the same way you have one on the left, there's one on the right, a REMA, right internal mammary artery. Now, this one can be a little tricky because the heart is turned and twisted a little bit to the left, so sometimes it doesn't reach. So that can make it a little bit more problematic. So it all depends on anatomy. The other option for an artery is to use the artery in the forearm, is the radial artery. And again, there's times when you can or when you can't. And we also worry about spasm when we take the artery out of the arm. And you also want to make sure that the hand still gets good blood supply if you take the artery. So that's also a consideration. Now, aside from that, the next conduits we use are veins from the legs. Now, the legs have a dual system for venous drainage. You have a superficial venous drainage. It's called a great saphenous. It's very superficial, sitting right underneath the skin. And then there's a deeper system. So usually we take the superficial vein, the great saphenous, and we leave behind the lesser saphenous. So long term, the leg doesn't really suffer. It's not like the leg is going to get swollen. Usually it recovers fine, so the venous drainage is going to be okay. So we take the great saphenous vein, we turn it the other way because the vein has valves in it, so you don't want to flow against the closed valve. So we turn it the other way and we use it as a conduit basically to bypass the area that's narrow. Previously, the incision used to be basically along the entire length of the leg. Now we use an endoscopic instrument where we just create a small incision at the groin, a small incision at the knee, and one at the ankle, and you create a tunnel underneath the skin to basically take the vein out. So it's pretty amazing, yeah. So the whole point of this exercise is basically with all the studies that we do, when you see the cardiologist, we know exactly what your anatomy is, we know exactly what your vessels look like, and we know exactly where the blockages and the narrowing areas are. And then we can bypass those areas just to restore blood flow. So in this case, on the picture on the right, we use that lima, the left internal mammary artery, to bypass this area that's blocked, so we connected it downstream. That way, even if this blocks completely, doesn't matter. Now you have new blood supply going to the heart muscle from this artery. This is a vein that was used from the leg. So basically this is the right coronary artery, and it looks like the bypass was down here, and the proximal part was connected back into the aorta. So now you're getting blood supply to the heart muscle through this vein. So, you know, heart operation is heart operation. So, you know, it is a big operation. you know. We do have to divide the breastbone in order to get to the heart. Now, the incision eventually looks like a thin, skinny scar, but it is a big operation. Now, the bone gets put together with wires or plates. You won't know they're there. You won't feel they're there. The only way to know is actually if you look at a chest x-ray. But bone tends to heal good, you know, heals well. So that's coronary artery bypass in a nutshell. Now, next I'm going to talk about a little bit about valvular heart disease, valves. So there's 4 valves inside the heart, like I mentioned before. Now, the valves kind of work like doors. It basically allows blood flow to go from one chamber to another one, and it prevents blood from going backwards. So it basically routes the blood through the heart in order to get oxygenated and then go to the body so that the entire body gets oxygen. Now, when the valve is too tight, for whatever reason, that's called stenosis. So the valve is tight, doesn't really open well. So the forward flow of the blood is actually inhibited. Now, there's several reasons why that happens. Some are congenital. You can't really control, you know, what you're born with. But the most common cause in the Western world is really degenerative. Over time, it just kind of wears out. So you tend to form calcium, the valve gets thicker, the commissures, the ends of it kind of fuse together, and then it gets tighter and tighter. There's some medications that can affect the valves, there's radiation that can affect the valves, rheumatic heart disease, so an infection, this is an infection-related process that eventually leads to the valve getting really, really thick and tight. So it doesn't matter really what caused it. If you get to the point where the valve is really, really tight, the heart will suffer. Initially, because the heart's trying to squeeze through a small area, the muscle gets thicker and thicker and thicker because it's trying to work harder to get blood across. Now, when it can only get so thick, eventually it kind of gives out and starts dilating. So that's kind of when the heart function starts getting lower and lower. So you want to catch it before it gets to the point where the function is decreased. Now, the way to fix this can be two different approaches. And again, there's specific indications when you would go one way or another. One is a transcatheter approach, for if we're talking about the aortic valve, where you go through the groin and you put a new valve within your native valve and you just kind of open it. 2 is a surgical approach where we would take your own valve out, completely cut it out, clean out that area, and put a new valve in. I'll talk about that in a little bit. Now, so when the valve is too tight, it's called stenosis. When the valve doesn't close well, so the leaflets don't come together, that's called regurgitation or insufficiency. So the leaflets are really thin. In the aortic valve, give that as an example. In the aortic position, you have 3 leaflets. So they kind of come together like this. So when the valve closes, the leaflets kind of sit like this and prevent blood flow from going past it. Now, if the valve is incompetent, the leaflets either don't touch, don't come together, so they're a little bit stretched out, or one of the leaflets is prolapsing, it's sticking out for whatever reason that doesn't allow it to come together, or where the valve anchors into the heart muscle is affected. So many different reasons why that happens also. Either the leaflets themselves are damaged or the supporting structure is damaged. Sometimes even like coronary artery disease, if you have decreased blood flow to the heart muscle, the muscles where the leaflets anchor, the papillary muscles, can be weakened or scar. That can lead to the valve not working. Or you can have an infectious process. So if there's an infection in the bloodstream, that can lead to an infection on the valve itself. Sometimes those leaflets can degenerate and actually perforate because of the infection. Or more rarely, there's a genetic condition where there's a mutation in one of the genes that affects the connective tissue. So the valve develops abnormally. And again, that's not something you can control, it's just a genetic condition. So what do we do for these valves? So one option sometimes is repair. Ideally, we would like to preserve your own native valve. That is the best valve you will ever have. So if we can repair the valve, that is actually best. Unfortunately, in a lot of cases, that's not an option, and we have to replace the valve. When we replace the valve, then the discussion becomes, should we, well, one, is it a transcatheter approach? Two, surgical approach. And again, there's specific times and reasons why you would go one way or the other. Now, if we're talking about surgical approach, then we talk about what kind of valve. There are two options. One, it's a mechanical valve, and two, it's a biological valve. So the mechanical valve is man-made. The leaflets, it's like that, the first one. So it has tilting leaflets. These are synthetic. They don't break down. But the downside of that, you need to be on blood thinners for the rest of your life. If you stop taking blood thinners and you form a clot on that, it's bad because it can stop working abruptly. Now, that can still fail if you have tissue ingrowth into the tilting discs that prevent that from working. So nothing is 100% fail-proof. The other option is a biologic valve, and that's made either from cow tissue or pig tissue. And they work beautifully. You don't need to take blood thinners with the biologic valve, but the downside of it is they do tend to degenerate. They are made of tissue, so they don't last forever. So with time, they kind of slowly degenerate. It can last anywhere from 18 to 15 years. In younger patients, they tend to degenerate faster, and there's certain conditions where they tend to degenerate faster, like end-stage renal disease, for example. But those are kind of the options that are discussed when we talk about valve replacements. Now I'm going to shift gears and talk a little bit about aorta surgery. Aorta is the big blood vessel that comes out of the heart. It gives blood supply to every other organ in the body. The first branches that come off the aorta are the coronary arteries. So those are the blood supply to the heart muscle itself. It's pretty genius. Feed yourself first. Then the arch, and then these are the arch vessels that go to the neck and arms. And then as the aorta descends, it gives all the blood supply to the belly organs and the legs. So indications for surgery on the aorta. Now, if the aorta is enlarged, and again, there's many reasons for all these things. If the aorta is enlarged or aneurysmal, there's specific cutoff criteria for when we talk about surgery. The reason why you need surgery when it gets to a certain point is if you do nothing, the aorta can rupture, and that becomes an emergency. So if the vessel is enlarged, if you have a tear or a break in the wall of the aorta, that's called a dissection. That is a surgical emergency. That's something that cannot wait. You need to go to the operating room now. If there's an ulcer that forms on the inside, it's basically an area that kind of slowly gets eroded. And again, the risk with that is, depending on how deep this ulcer is, the vessel can completely be penetrated and then you bleed. So that becomes a surgical emergency as well. And then if you have a clot inside the wall. Now, the wall of the aorta is actually pretty thick, so it has its own blood supply in order for it to survive. So sometimes you can form clots inside the wall of the aorta, and if that continues to expand, then that becomes problematic again because it can rupture. So those are kind of the reasons why you would need the aorta operated on. When the aorta is enlarged, depending on what size, you can kind of slowly watch it, and once you get to a cutoff size, then you talk about surgery. And what we do for that is basically we take out the segment that's enlarged and we replace it with synthetic material. Sometimes it involves the valve itself, the aortic valve, in which case you would need a valve replaced. If it involves the area where the coronary arteries come off, then those would need to be reimplanted as well. And I just wanted one more, I didn't include a slide, but one more thing about an operation for arrhythmias. I briefly mentioned it at the beginning as one of the reasons why you operate on the heart. Now, typically you don't go to surgery just to operate for an arrhythmia reason, but if you do have arrhythmias, like atrial fibrillation being the most common, if you go to the operating room for your heart and you have arrhythmia, then that's something that would be addressed at the same time. the heart, like I said, it's a muscle, and you need electrical stimulation for the muscle to contract. There's different areas of the heart where the conduction starts and it gets perpetuated in order to make this contraction happen. The top chambers of the heart can have this like abnormal, if they become irritable, can have this abnormal areas where you can initiate a conduction that's called atrial fibrillation. Now, the surgery we do for that is called an ablation. Either freezing the tissue or using radio frequency, you basically create scars in the muscle of the heart at specific areas, and you're basically creating roadblocks, so you don't allow the conduction to be haphazard all over the place. You're basically creating this roadblock so the conduction kind of gets rerouted to where it normally would go in order to have a normal contraction. So that's called ablation for atrial fibrillation. So I know that's a lot of information. Thank you.
Thank you so much. Thank you so much. I think we all can graduate now with a degree in medicine. And while the Hanson Place Men's Chorale is coming up, to sort of just break the, for you to digest all the good things that have been said before, we will, Dr. Camacho, this is a treat for you. This is a Hanson Place Men's Chorale, and we're going to be trying, we're going to do a Negro spiritual. This is Black History Month, and we're going to be doing a spiritual about praying. Oh Lord, hear my prayer. I just want this audience to know that last year, Dr. Camacho made a very, very stellar contribution to the Hanson Place Church and to the she gave us one of the most expensive instruments that we could ever see. So we just thought we're not going to be using the instrument today, but so that you can we can legitimize your contribution. We're so thankful to you for it. Yeah. I just don't want you to go back to the hospital and tell them that I'm doing this, okay? hands together for the Hanson Place Fence Corral. So, our next presenter is Dr. Margarita Camacho. This is no ordinary lady, one of the most recognized heart transplant surgeon in the Northeast. Has done more than 1,000 heart transplants. Actually, when she came to about, what, 20 years ago? 18 to be exact, you know. She came in with a lot of energy, and I don't know what happened, but that energy has never waned. It has continued all over the years. So she is the president of the Society of Women in Thoracic Surgery and a fellow of the American College of Surgeons. She most recently received the American Heart Association 2017 Harvey E. Nussbaum Distinguished Service Award. Excellent. Dr. Camacho has served as one of the directors of the Founders Affiliate Board of the American Heart Association and a trustee of the Vassar College, where she is passionately a supporter. Of course, Dr. Camacho has authored many journals and basically is a principal investigator of numerous clinical research trials involved in the treatment of end-stage heart disease. So the primary care doctor does what he or she can, passes the patient to the cardiologist for continuing care. And then the cardiologist determined that we need some surgical intervention. So Dr. Jotar takes over. At a certain point in the process, we realized this patient needs a new heart. And so, they go to the finest lady. Put your hands together for Dr. Margarita Camacho.
Thank you so much. So Dr. Braverman just leaned over to me and said, that's a tough act to follow. Hanson's Van Choir. I totally agree. So I must tell you, though, when I came to our health system 18 years ago and I met Lincoln, I thought to myself, I've never met anyone like him. He was all-embracing about every aspect of our program. He is the chief PA, but he's been a PA for many years. He really, the most experienced. He embraced not only his PAs, he would be in there in the operating room teaching medical students, residents in surgical training. It was incredible. So I immediately nicknamed him the professor. And throughout the years, I must tell you that his dedication and his commitment are unparalleled. Okay? Dr. Blackwood does not have a call schedule. If you need his expertise, he is there. And I've just never seen anything like it. And then when I see what he does outside, and I said to him a couple of years ago, I really wanted, because I knew he wasn't going to take a gift from me, a gift card or whatever. I just wanted to show my appreciation for all that he's done. And I said, look, I want to make a gift in your honor. And that's how the gift to the Hanson's Place Church happened. It's because someone continues to pay it forward. And I can't think of any better way and any better privilege for me to help but to honor him. And so I thank you for everything you've done and continue to do. I mean, you're totally the quintessential human being all around. So, I've been in the heart failure surgery field for over 20 years. And I have to say, as Lincoln mentioned, when we can't do any more for the heart, then you've either got to replace it or find some way to support it. Because heart failure is a I'm sorry? Okay, thank you. Heart failure is a huge problem in this country. It is the most common complex heart disease. About 6.5 million people in the United States who have it. Almost 1 million new cases are diagnosed every year, and it is unquestionably the #1 healthcare cost in this country. We estimated $31 billion was spent because of heart failure, and this includes days of lost work and non-productivity. And we're estimating that by 2030, it'll be $70 billion. So what are the risk factors? So what you've heard before. If you have severe coronary disease and it's progressed, and maybe you didn't know it because you didn't have many symptoms, you're getting more tired, et cetera, but you don't know you have severe coronary disease. By the time it gets diagnosed, they may have diagnosed advanced heart failure. And these are all the other risk factors which you've seen. Poor nutrition, physical inactivity, and alcohol. There is actually an entity in heart failure. It's alcoholic cardiomyopathy. Cardiomyopathy is disease of the heart, but advanced disease. So alcoholic means it was probably caused by alcohol. What are the symptoms? They can be really nondescript, like just shortness of breath when you're doing your daily exercise. You're noticing that you're more short of breath. You may have trouble breathing lying down because fluid is building up in your lungs. You could have weight gain with swelling of the feet, legs, ankles. And you can just generally feel tired or weak. So these are pretty nondescript. All the more reason you've got to go get your annual checkups, okay? Because that's usually the first place when they can try to at least come up with some objective reason for why you're feeling that way. What's a treatment? So GDMT is a very commonly used term in the heart failure world. It's guideline-directed medical therapy. That's the special cocktail that after maybe a month or two, your internist or your heart failure cardiologist will come up with a cocktail of medications that'll make you feel better. And it's a bunch of different kinds of medications, and within each class of medication, there are different types, and they may choose one because you're diabetic, not diabetic, but the bottom line is, to get to that special cocktail of medications, you've really got to be followed closely by your physician. Now, there are two types of medications. The first, they always try oral first, and if that fails, they might recommend a continuous medication. Now, what does that mean? You actually go home with the pump. It's a pump that goes, they put a special intravenous line that's a bit long in your arm, and it's managed by a visiting nurse that comes to visit you every few days or every week. And there's a pump that you wear, sort of like a very small shoulder bag, and it'll have the medication going through you continuously. And that medication, it's usually milrinone, is actually very effective. We've seen heart failure patients be really debilitated and exhausted, et cetera, and like you start them on a low dose of it, and all of a sudden they can drive, they can, do more activities. So it's actually very effective. And we've had patients home with this medication for years sometimes. So it's very, very effective. But the point is, you're not going to be able to get it unless you get followed up and that you get diagnosed. Obviously, you'll have to reduce your fluid intake and sodium or salt intake. Now, if all that medical therapy doesn't work, then you come and see people like me, okay? And at that point, there's really two basic types of surgery you do for end-stage heart failure. One is to use a mechanical heart pump, and the other is to do a heart transplant. Now, which of the two do you choose? There are a lot of factors that come into this. Usually we try to consider someone for heart transplant first. The problem is, as you know, there's a tremendous donor shortage in this country and around the world. So that isn't always available to everybody. But starting with the heart pumps, now the heart pumps we will tend to use in patients who are older, over the age of 75, or people who have other health problems that would not make them a good heart transplant candidate, people who are actively smoking. In order to be a heart transplant candidate, we want to make sure that you're compliant with your medication, because when you get an organ transplant, you need to be on immunosuppression therapy. So what is that? It's exactly what it sounds like. It's medicine that depresses your immune system so you don't reject that organ. If you don't take that immunosuppression therapy, you're going to die. Okay, and that we've seen that happen to some people. And so we have to make sure that you really are going to do everything we say. And one of the measures we have for that is stop smoking, stop any kind of drug abuse, ethanol, whatever. Now, there's other reasons for that too. It's not just your compliance. If you smoke and if you drink, you're decreasing your life, your lifespan or your survival. And we owe it to the donor, okay, who's giving you the heart, that you live as long and as healthy and productive life as you can. And so, as a heart transplant team, we're the stewards of organ allocation. We have to really, since this organ is so scarce, we have to try to allocate it to the patients that are going to live the longest life and make the best use of it. And so if you're not a candidate for heart transplant, you can be considered for a heart pump. So a heart pump actually takes over the work of your left ventricle. Dr. Drotar mentioned the two ventricles, the right and the left. The right brings the blood to the lungs, the left brings the blood to the entire body, the rest of the body. So if your left ventricle is not working, the rest of your body is not going to get all the blood that it needs. You'll start to develop kidney failure, liver failure, etc. So these pumps take over the work of the left heart. They're all inside the body. The only thing that exits your body is a cord that some people consider a lifeline. It's called a drive line, and it's attached to the batteries that keep the pump going and to a little computer that tells the pump what to do. These are the generations of pumps that have been made over the years. The one on the far left is pretty big and clunky. It's no longer made, but it was, we started implanting it in the late 80s, and it allowed people to go home and live a productive life. The problem is, it didn't last more than 2 or 3 years. And so, and replacing it was a big bloody operation. But it was the first pump that, again, that allowed people to live, to have some survival, and to go home. So back in 2005, we used that pump until about 2006 or 7. In 2005, we started doing clinical trials on that middle pump, which is really the workhorse pump. It's called the HeartMate 2. It's much more technologically advanced. It's the pump that Dick Cheney got, if any of you remember. He had a heart pump. And so that was FDA approved in 2008. And then the real Rolls Royce of pumps is the HeartMate 3 on the far right. That is extremely technologically advanced, and it's expected to last about 15 to 20 years before breaking down. The middle pump was only expected to last 5 to 10 years, but in some patients, it's lasted a lot longer. So the pumps work the same way, pretty much. They drain blood from this. This is the left ventricle. The blood goes into the pump, and the pump ejects it out into the aorta. And that's exactly what your left ventricle does. So it's acting like your left ventricle. So your left ventricle could be really impaired, and this pump will keep you alive. This is the line I talked about. This is all in the body, but it exits the body here. It's the drive line or lifeline, and it's attached to a computer controller that tells it what to do, and that's attached to 2 batteries. You always have to wear 2 batteries, okay? Because when one starts powering down, the computer makes a faint noise, and if you don't pay attention to it, it makes a blaring noise, because if that pump stops, you could die, and that has happened to people. Okay, the batteries last about 10 to 12 hours each, and they're a lot lighter. Because I remember in the olden days, they were very heavy, and they only lasted 4 or 5 hours each. This is the HeartMate 2. That was the middle pump. It's still made, but I think probably, I would think in a couple of years, they'll stop making it. But the reason I put this slide up is this is 2 years old. This is from March 2021. And by that time, 27,000 had been implanted around the world, mostly in the United States. But the reason I put this slide up is because at 10 years, so these are people still alive at 10 years, 444 patients still walking around with the same pump at 10 years. When we were investigating this pump, and at New York Beth, we trialed every single FDA trial pump. So we really didn't think it was going to last more than maybe 7 or 8 years. So it really outperformed what we expected. This is a HeartMate 3, the Rolls Royce of pumps, and this, again, this slide is 2 years, I think, old, but at 6 years, or 5 years, yeah, 5 years, there are still some people walking around with it, and the main reason I actually put this up is that, there in 5 or 6 years that this pump was implanted, we had already implanted 16,000. That previous slide was a 15-year span, and we had implanted 27,000. So clearly, our use of these pumps has skyrocketed. And I love this pump, and I really think that this will be an amazing alternative to heart transplant. So the pumps are amazing, and why do I put this up? I've seen pictures of about 3 or 4 brides walking down the aisle with pumps, and you would never know it, okay? They're very well hidden. We have a patient, this is our patient, Myra. She's actually been in the, she's been publicized. She actually spokesperson for pump technology. She was 29 years old when she came to us in April of 2008, and she had a 6-month-old baby at home. And she's told her story publicly. She was transferred from another hospital because she was admitted to that hospital with the flu, and when she just didn't get better, after 2 days, they did an EKG. Remember, she was 29, so I mean, who would think she had any heart disease? Her heart was barely moving. The EKG was extremely abnormal. They did an echo, which is a sonogram of the heart, and it was barely moving. So they quickly transferred her up to New York Beth Israel, and within 36 hours, she had a full-blown cardiac arrest. I'll never forget this. It was midnight, and I was away, and my partner put her on life support. And we didn't think she was going to make it through the night, but she did. And when I got back 2 days later, you know, she had awakened and all that. She was still on the life support. And we switched her over from that life support, which is ECMO, which is a temporary device that you can quickly put someone on. We switched her over to the HeartMate 2. So that was April of 2008. This is from the Grand Canyon about, I want to say, 5 years ago. About 3 to 4 years ago, she was honored at the American Heart Association ball in New Jersey as being one of the most amazing survivors. And I have to tell you, when she told her story, and her 6-month-old baby back then was a very handsome, wonderful 14-year-old boy, there wasn't a dry eye in the room. She just really beat all odds. This is what her life is like. She's extremely active. She has the same pump that we didn't think would last 7 or 8 years. She is now, this May or April, going to be celebrating her 15th anniversary with the same pump. So this is her showing. I'm just showing you how you can hide the pump, or at least the peripherals. We had a press release last year in April to celebrate her 14th anniversary. And this was what she did when the photographers and the reporters wanted to see where her pump mechanics were. And there she was, all hidden under her dress. So you can really live with these pumps, not just an active life, but really no one would know you had it, if you cover them up well. So for those who can be heart transplant candidates, it's a long journey. It takes at least a month and that's expedited, at least a month to work you up to make sure you are a heart transplant candidate. There's a punch list that's maybe 30 items long. But if you do if you fulfill everything and we put you on the list, then I have to say, I mean, it's a great life because you're not tethered like to a driveline. You tend to lead a relatively normal life after the first year. The first year, you really have to worry about infection because that's a time when you're most vulnerable. Because the first year, at least the first 6 months after a heart transplant, your body is at its highest, at this heightened response to try to reject that organ. And so your immunosuppression doses, drug, are at their highest levels because your body's trying to reject. But that tapers down after 6 months. And so after that time period, you can pretty much lead a relatively normal life. So the first heart transplant, probably remember, just from stories, is from 1967 in South Africa, Dr. Christian Bernard. This was a recipient, Louis Washkansky. He was 53 years old at the time. The donor was a 25-year-old woman who had suffered brain death from a car accident. Now, back then, we didn't know anything about immunosuppression. This was our first heart transplant. We had no idea how much to give. And if you give too much, you can have fatal complications like overwhelming infection. You can have serious complications like renal failure, kidney failure. And so, unfortunately, he didn't live very long. He just lived a few weeks. But, it was our first step, to that journey to figure out how to do it best. And so, many years later, with our technology, et cetera, we've really almost perfected the immunosuppression. We really have, so that patients can continue to lead a relatively normal life and not suffer from some of the really serious side effects that they can cause. So heart transplants, again, because of organ donor shortage, they're limited in number. This is a graph showing the heart transplants around the world. Yellow is Europe, the green is North America, mostly the United States, and red is the rest of the world. Now, here you'll see that there was an uptick in 2016, 17. So why is that? Well, unfortunately, when I first started doing heart transplants 20 years ago, many of our donors were brain dead from car accidents. And what's happened recently is it's turned around, and unfortunately, it's from opioid drug overdoses. So I will say, I don't have the exact number, but if I had to guess, about 70% of our donors are now from opioid addiction and from drug overdoses. Yeah, it's sad. And that trend has continued, unfortunately. CNN picked up on it actually, several years ago. There was an article about a 24-fold rise in organ transplantation, because of overdoses. So that has increased the number of donors. So what else have we done to try to increase the number of donors? We've actually accepted hearts as long as the recipients are okay with it. And we always get their permission before we do this, but we have accepted hearts in the last six or 7 years from hepatitis C donors. Now, why is that? Because hepatitis C is so treatable now. It's treatable with oral medication for 1 to 3 months, depending on what drug you're taking. And it's better to if you seroconvert and you develop hep C from your donor heart, it's better to be treated, easily and live rather than to die on the heart transplant waiting list, right? So I would say that 99% of our recipients agree to hepatitis C donor hearts. The remaining 1%, they just are stubborn. But, we try to tell them, you may die on the waiting list. And we have shown that the outcomes from hepatitis C donors are no different from the non-hepatitis C donors. Okay, the same survival and the same complications post-op, the same complication rate. No increase from hepatitis C donors. And finally, one of the other ways we've tried to increase the number of donors is by using a heart pump. So first I have to tell you what an ischemic time is. An ischemic time is the time that the heart is not beating, the donor heart. So when we take the heart out of the donor and we put it on ice and we come back to our hospital and put it in the recipient, all that time is ischemic time. The heart's not beating. The heart isn't beating in the recipient until we sew the heart in, right? And we get it started. So once you sew it in, it starts right away. But that period that it's not beating is called the ischemic time. And we like to keep that ischemic time under 4 to 6 hours, depending on the age of the donor. The younger donors in their teens and 20s can have an ischemic time that's longer, probably up to 6 hours. But the older donors, those 40 and above, you want to keep it 4 to 4.5 hours. So one way to get around this, and we've had many offers from faraway places that we have not been able to accept because of distance. One way to get around this distance problem is to have the heart beating as you're traveling. And so we were very fortunate at New York Beth Israel to be one of the first centers in the country to trial this in 2010. We found it was wonderful. When you remove the heart from the donor, you hook it up to this device. You take about 1 liter of the donor's blood so that it can circulate through the heart. And what this device does is it circulates the blood into the heart so the heart is beating. It's really the most physiologic way to transport a heart and keep it viable. So with this, you can easily keep a heart beating for 8 to 10 hours. I believe the longest that they've used this for a donor was up to 18 hours, I think, somewhere in the Middle East, actually, where the recipient did fine and walked out and was fine 3 or 6 months later. So this will have a lot of promise because there are remote areas that we can't get to easily because of this ischemic time problem, where we can travel, with the heart and keep it viable. Right now in the United States, we used to do, I want to say about 3,100 to 3,200 transplants a year, but because of the opioid epidemic giving us more donors, because of taking hepatitis C hearts, and soon because of the use of this device for distance, I really think we'll probably be able to reach about 4,000, that number soon or before long, yeah. And so all these new technologies we do are great. They've allowed us to give life to more people with respect to the pumps and the transplants, but none of that is any good if they don't get the best postoperative care. And one of the keys to our success is not just what we do in the operating room, but what happens to the patients after the surgery, when they get out into the intensive care unit, where they get to benefit from the incredible technology that we have now. So thank you very much for allowing us to share our little world with you.
Thank you, thank you, thank you, thank you. There's a car that is blocking the driveway. It's an Infiniti SUV blocking the driveway over there. Please, someone has to get out. That was a beautiful segue, Dr. Camacho, because I would like to, and thanks for the presentation. You have seen all the many different interventions that are necessary when the heart goes bad. Do not allow it to get there if you can help it. And so this meeting and these seminars are not just to talk, it's to sort of give you the full scope of what happens to your heart. So you can start from now to protect it. But then our last presenter is Dr. Braverman. So, let me get to my note here, Doctor. So, Dr. Braverman is really, I can tell you this, when we approach the table and we are there deciding what should be done, after we have decided what to be done as a surgical team, Dr. Braverman will say, like, valve number 23. And Dr. Sadari, our surgeon, will come in and say, what did Joe say? It's valve number 23. Then it is valve number 23. You know, I consider Joel my brother. Ever since we worked together for a very, very long time, about 15, 17 or more years. You know, I respect him a lot. He's a family man, apart from his clinical acumen. He's a graduate of the New York Presbyterian Hospital, Weill Cornell Medical Center. He did his internship there. He is a cardiac anesthesiologist. He's the chairman of the Department of Anesthesia for Cooperman Barnabas Medical Center. And he has earned that based on his clinical acumen and his intelligence where the cardiac care is concerned. So when we have done all the surgeries on these patients, we send them up to the unit, and Dr. Braverman is there. He is the one who will see them through. Put your hands together for Dr. Joel Braverman.
Thank you, Lincoln. As Dr. Camacho mentioned, Lincoln has been with us through thick and thin for all these years. He's been a brother, he's been a colleague, and he's been an inspiration not only to us, but my daughter, who recently rotated with Lincoln this past summer. He was her mentor and has inspired her to become a physician assistant. So I just wanted to say thank you. As great as all the clinicians here are, there are certain things that we cannot fix. As pointed out, stress affects us all, broken hearts, but it's places like this, the faith, the love, the support that you all give that can help to cure the heart that we cannot. So first, thank you to all of you for the support that you guys give here to fix the broken heart. When Lincoln approached me about this, I kind of thought about, well, February is Go Red for heart disease, women and heart disease. And first and foremost, we have to think about, well, how do we diagnose and treat? And the first thing we need to do is identify the problem. And what most people don't realize is that cardiovascular disease is the #1 killer of women. 1 in 3 deaths in this country are caused from cardiovascular disease. It impacts women at higher rates than others, but most cardiovascular diseases can be prevented with education and a healthy lifestyle. Heart disease and stroke can affect a woman at any age, which makes it vital for you to understand your risk factors, your family history, which means you need to go see your internist and discuss your risk factors. It's surprisingly that cardiovascular kills more women than all forms of cancer combined. Yet, little less than half of women recognize that this is their greatest threat to their health, is cardiovascular disease. 10 to 20% of women will have a health issue during their pregnancy related to high blood pressure, preeclampsia, diabetes, and that greatly will increase the risk for cardiovascular disease throughout life. Most of cardiac and stroke events, as I said, can be prevented with education, lifestyle changes, moving more, meaning walking, exercise, eating smart, and very important, managing blood pressure. Almost 52% of high blood pressure deaths, otherwise known as hypertension, or the silent killer, are in women, and it affects black females who have hypertension much more significantly than any other ethnicity. Women are also often less likely to receive CPR because rescuers are concerned about inappropriate touching or injuring the victim. Obviously, many of you know what just happened to Damar Hamlin and how CPR saved his life. So I would encourage all of you to go out and get trained in CPR because it can save your family, it can save your neighbor, it can save your friends. So please, please go out and get trained in CPR. Even when we do all the things we're supposed to do, oftentimes we still need to have heart surgery. As Dr. Girotar mentioned, open heart surgery requires opening up the chest. A machine is connected to the heart that temporarily takes over the function of the heart and lungs. And then the surgeon operates on a heart that isn't beating anymore. After the surgery, the surgeon wakes up the heart, disconnects the device, and the heart starts to work again now that its blood flow has been restored. Open heart surgery has risks like any other surgery. The risks are increased if you have diabetes, if you're obese, if you smoke. Actually, smoking is probably the biggest risk for postoperative complications. I put this picture up here because Lincoln has heard me use this analogy where the old car looks great driving down the road. Then it hits a pothole or it gets hit by another car. And then you realize that the old car has a lot of old parts. And it's my job in the ICU that when the car looks like this after open heart surgery, to try to put that car back together again. And that because even if the car's engine is fixed, the heart, there's a lot of other parts that are damaged or have been stressed. The lungs, the kidneys, the liver. So it's also incumbent upon all of you to try to do the things in life that we can all do to try to minimize the damage to all of these other parts. And that means not smoking, that means exercise, that means controlling your blood pressure, taking your blood pressure medication, and treating your diabetes, because that helps you, that helps the surgeon, and it helps all of us get you back to what we all want, and that's to be driving down the road again. In the red car, that's it. Thank you.
Wow. I would like you to put your hands together for the excellent presentation that we've had here this evening. And we have learned a lot. And do we have, I know that there are a few questions that I don't mind if this panel will field a few questions from the audience. We're going to ask the mics to be set up here. I'm sorry? So while we're getting ready for the Q&A, we're going to be entertained by the God's instruments. These are beautiful children while we get the stage ready and everything ready for this presentation. Put your hands together for God's instruments.
I don't want to call you guys out in the mic, but my cameraman, Matisse, can you come down, please? Ruben is coming. Guys, give it up for Ruben. And give it up for Matisse that's on his way. Yay, Matisse is here.
Yeah, hooray. He said move.
All right, the song that we're about to sing is called There Is Hope. So I know that you guys heard a lot, and some of you may question your health, but there is hope, okay, that you will be better. There is hope that everything will work out. There is hope that the trauma or the problems that we are facing, God will give a solution and we will have victory. There's hope that we'll all get to heaven and see our God. So this is a children's choir, God's instrument. I hope you enjoy the song.
People are dying every day. Sickness is taking them away. Children are crying all around. A solution must be found. Seems like racism won't end, and that People are dying every day. Sickness is taking them away. Children are crying all around. A solution must be found. Yes, there is hope. Lord, there is hope. There is hope for all. There is hope. As long as Jesus is alive. Yes, there is hope. Yes, there is hope. Lord, there is hope. There is hope for all. There is hope. As long as Jesus is alive. Yes, there is hope. Yes, there is hope. Lord, there is hope. There is hope for all. There is hope. As long as Jesus is alive. Yes, there is hope. There is hope. Yes, there is hope. There is hope. Yes, there is hope. There is hope. There is hope. Yes, there is hope. Yes, there is hope. Yes, there is
Wasn't that beautiful? Wasn't that beautiful? Come on, make the children feel a little better. Give them a round of applause. So we could be setting up some mics in the corridor and field a few questions from the audience. We'll use this one here. but out of respect for the audience and the need for you to ask questions and get some answers, we are going to extend the time a little. And so we have two mics lined up. There's one on either side. I'll go alternately and field your questions. If you want to direct your question, pass it to any of the presenters, fine. If not, if it's just a general question or Lady Higgins, you're welcome to do so. So please go ahead.
Can I get this mic activated?
It is. It is.
Okay. I can hear myself. Okay, I had an incident with my grandson when he was 18 months. He was hospitalized, and for 11 months he was in the hospital because he had what was diagnosed as a pathology of the palate. Whatever that was, I didn't know, and I still don't know what that is. And then it is called blue baby syndrome. And they said that only 3 chambers of the heart was working, and they had to do some procedure to get that 4th chamber activated. And I'm still not sure. Now he's 25. That's a long time ago. And I still didn't have the answer and couldn't understand why we had to live on that hospital campus with that baby. And the whole family was traumatized by the condition. And I really don't understand. Can somebody sort of enlighten me about what was going on with my grandson with this blue baby syndrome and tetralogy of palate?
All right, so, Elder Higgins, thank you for your question. I was just telling my co-panelist up here that I submitted a bio. They didn't read it, but in the bio mentioned you because you were one of the reasons why I'm a pediatrician today. When you had me work with you at God's Garden, and I realized that I didn't hate children. So thank you so much. And I'm going to explain to you what tetralogy of Fallot is. The tetra part of it is that there's 4 issues with the heart. So 4 things went wrong, but I can't really call it wrong because one of the things, which is a hole in the heart, actually allows the baby to survive and be born. So that's one of those congenital heart diseases that we talked about, something you don't have anything to do with. It's not the mother's fault. It happens. But what it does is it causes the blood not to flow in the direction it doesn't flow the way it should flow, okay? And that's why the babies turn blue, right? Now, what they can do is when they're walking, some babies will do this, like when they're 1 or 2 years old, they'll squat. And when they squat, it pushes the blood into the direction it's supposed to go. So it's a little complicated, but I'm gonna let the intensivist explain why you were in the hospital for 18 months, but that generally, those are one of the congenital heart diseases that we just alluded to. And I'll go over with you exactly what those 4 things are.
Okay, thank you.
Does this work?
Yes.
Okay. So, yes, it's a congenital condition, meaning you're born with it. So during development, like when I mentioned the heart starts out as a tube with one side where the blood goes in, one side the blood goes out. This tube kind of folds on itself and kind of twists. And while this is happening, there's different proteins in the body that coordinate things that open inside the heart, that close inside the heart so that you can have complete separation of the 4 chambers, and you form the valves in the right position, and you form the big vessels that come out of the heart in the right position and orientation. Now, with tetralogy of Fallot, there are several things that are abnormal. The right side of the heart is a little bit stretched out because the valve that goes into the pulmonary artery, where the blood goes towards the lungs, that valve is really, really, really tight. And the pulmonary artery is really tight. So the right ventricle is struggling to pump blood into the lungs, which means the blood is not really getting to the lungs to get oxygenated. So that's the blue part. because these kids tend to be what we call cyanotic. That means their oxygenation inside the body is on the low side because the blood flow to the lungs to pick up oxygen is abnormal. Now, in addition to that, there is a hole, there's an opening between the left and right ventricles, which is abnormal, should not be there. So there's shunting of blood inside the heart. Now, there's this whole separate specialty of congenital cardiac surgeons, which spend additional training into operating on just babies. I don't do that, none of us do that. But when you have a patient with a tetralogy, basically that heart will never function like a normal heart. So the blood flow is rerouted so that it picks up oxygen. There's 3 different procedures that you have to perform, and it's a staged operation. So initially, it's the life-saving operation to where you have to get some mixing of blood from the left and right heart so that you have oxygenated blood going to the body. But with time, as the baby grows and the blood vessels get bigger, you have to reroute blood flow. So by the end of the 3rd procedure, essentially you're still getting blood flow oxygenated to get to the left side so you can get to the body, but it's rerouted in a different way. So it's a staged operation. It takes a long time. So I assume the baby was sicker in the beginning, so they kept the baby to where he was well enough and gained enough weight to sustain a big operation, and then they allowed him to grow to the point where they could do the second part operation. So usually it's a 3-part operation for a tetralogy.
I just want you to know that that baby is alive and well right now. There's no more baby. He's a grown person, alive and well. Mike 1.
Yeah, first of all, I want to say thank you to the panel as a pastor of a church for this wonderful and informative session that we have had today. Thank you so very much. And to Dr. Camacho, 2 things. I want to thank you for your gift as well. We thank you. Now I know who was the donor in person, so we appreciate you. But
anything I can do to help you.
thank you. Thank you so much. So my question is to you, Dr. Camacho, because I got intrigued with the heart pump, and then as you finished your presentation, I wondered, what happens to these people who are living on a pump that seems to be expired or is going beyond the time that it was supposed to work? Are they just waiting to fall on and die one day? What's the hope for these people? 15-year pump it was supposed to be done at 7, now it's 15 years. What's hope?
Yeah.
What is the hope for them?
No, that's a great question. So the pump's computer is extremely, sensitive. And so if there's any sign of trouble, alarms start to go off. And there are 2 types of alarms. One is gentle and one's blaring. And so usually you're warned ahead of time if the pump is beginning to malfunction. I will tell you, though, that very few of these pumps malfunction. We haven't had a patient have a pump malfunction from, let's say, old age of the pump. So that's why we have these people walking around. I showed you Myra, who's approaching her 15th anniversary. There's somebody out there, I think the longest survivor with that pump has had the same pump in for 18 years. So, but when this pump starts to fail, if it does, I'm assuming it must, the alarm will start to go off. And what happens in that case? There's usually more than enough time to get to the hospital. We can put you on another kind of support if you need it. But more likely, we can arrange to have an operation to change it out to a new.
Oh, okay. Thank you.
Yes, you're welcome.
Okay, we have well, before that question, we'll take one question from online. This person would like to pursue the field of cardiology, and so they are pretty intrigued with the presentation. How long does the sternum take to heal after the incision, and what happens if you get a sternal infection? This is from
Those
online.
are really good questions. So any bone that you fraction in the body, it doesn't matter if it's a car accident or you fall off a bike and you fracture a bone, when the bone gets fractured and you put it back together, it takes about 6 to 8 weeks to heal. Now, in this case, we create a bone injury. We basically divide the bone and we put it back together with wires. So usually it takes about 6 to 8 weeks for it to heal. Now, one of the things that we tell patients after they leave the hospital is to protect the sternum. No heavy lifting, no pushing, pulling, no driving for about 6 to 8 weeks. And it's not that they can't drive, we just don't want the airbag to deploy. God forbid something happens, somebody in front of your car, and the airbag goes off. So 6 to 8 weeks. Now, sternal infections do happen. The risk factors, smoking, mentioned before, is one of the biggest risk factors. Diabetes, uncontrolled diabetes, and obesity are the risks, the risk factors that increase your chance of getting a wound. Now, if it's superficial, antibiotics will take it. If there's drainage from the wound, we have to open it and sometimes put a different kind of wound. Rarely, the infection goes all the way to the bone, in which case it can become more problematic because it takes longer to heal, and it may need additional operation to actually debride the bone. Sometimes that bone can't get put back together, and you need a flap. So sometimes from the chest, or even tissue from inside the belly to cover that whole middle and allow that.
Thank you so much. We'll take our next question.
Hi. My question is, the pastor mentioned a pump. Is the pump the same thing as a pacemaker, or is it something different? Because my question is, what's the difference between a stent and a pacemaker? And
Between what?
A stent.
a stent.
The difference between a stent and a pacemaker.
Okay. First of all, the pump is different from a pacemaker.
Oh.
A pacemaker really just helps take over the electrical activity of your heart when the heart doesn't beat as often as it should.
Right.
But the pump is actually dealing with circulation, with blood.
Oh.
It's actually taking the blood from the ventricle that's not working and distributing and bringing it over to the aorta so it can go to the rest of your body. So it's really taking over the work of the left ventricle. Now, a stent is like, it looks like a metallic, a circular, I don't know, tube, mesh. It's a circular mesh tube that comes in various sizes. And for the coronary arteries, it's very small. But what it does is after you open up a clogged artery with a balloon, okay, that's called an angioplasty, you can then put a stent in it to keep it open so that it doesn't narrow down again,
Now,
with time.
So the other part to that question, with a stent, does it the mic?
Go ahead, we're here.
No, it was the mic.
We're hearing you.
Okay, can you hear me now? Okay, so with a stent, if a person gets a stent, an elderly person, say about 75, 80, maybe 80 years old, and can they outlive the stent? Because I know I heard one of the doctors say, not a peer, but personally say that the person could have the stent for about 20 years.
It's variable. Every patient's different.
Right.
And it depends on how prone you are to develop recurrent hardening of the arteries or atherosclerosis. Everybody's different. But I would suspect that most people outlive their stents, right? I think, don't you think? Yeah. That's just a guess. Stents are pretty good at keeping the artery open. Now, that said, I mean, if you're one of those people prone to atherosclerosis sooner than later, you might get narrowing of within the stent, okay? And in those cases, they can usually re-balloon that area, okay? And put in and open up that artery.
So I'm sorry.
Right?
I just wanted, because with that, can the person, like, if the person outlives the stent,
Yeah.
and they're an elderly person, would it be a risk for them to do the operation, say if the person is 90 years old?
Okay, so if the stent fails and you're like 90 years old, is that what you mean?
Right.
Okay, so, well, we don't operate on a lot of people, open heart, okay, over 90. Occasionally we do. They're very well-selected patients who have to be perfect in every other way. But if there is any way not to do that, meaning re-balloon, reopen within the
That's what I mean.
stent,
Right.
we will do that.
Oh, okay. Just
Okay.
information.
Thank you so much.
Appreciate
We
it.
have two questions before we take the next up from online. We have a very, very active online viewing right now, and thanks all you viewers. What is the effect of opioid addiction on a heart with respect to transplant? With respect to the transplant, you mentioned that the opioid.
Yeah, so first of all, with the donors, unfortunately, people have become addicted to opioids. They have, as you know, they overdose. And what happens is there isn't someone around to give them Narcan or whatever, and they suffer brain death because of lack of oxygen to the brain. And so in order to declare someone a donor, they have to have suffered brain death. And so that's how this all happens. It really starts with the overdose, with, just going out and not having enough oxygen to the brain.
Yeah. So I guess essentially the opioid overdose caused the death of the patient.
Well, Lincoln, hold on a second.
Yeah.
I didn't understand the question.
Yeah, okay.
Okay, no, that's a really good question. Actually, I think what you want to know is, do opioids damage a donor heart, right? Okay, sorry about that. They actually don't if you're young, okay? Because we were one of the first programs in the country to take donors, and this is going back 20 years, take donors that had a drug overdose, okay? And other other transplant programs wouldn't, because they thought, oh, wait a minute. We all know that drug and alcohol, they affect the heart, but they don't usually when you're really young. Okay, so that's why, and we've shown over the years that those hearts have done just as well, as long as you're under the age of about 30, 35. And unfortunately, a lot of the opioid overdoses are on people that age.
Dr. Braven, in terms of the post cardiac care, I mean, does previous exposure to opioid really affect the outcome in the ICU setting?
Well, the biggest challenge that we have is pain control for these patients that are addicted to narcotics. It's difficult to maintain them with respect to that they've been used to and exposed to narcotics, often for many, many years, so difficult to treat their pain. But otherwise, from a hemodynamics, from the rest of the body, they do quite well.
Okay. Thank you very much. We have a short question.
I have a question for myself and a question for someone else.
We'll take one question for yourself first.
Okay, so my question is that oftentimes as doctors, you see things that are outside of your scope, something like a miracle. And do you address it and realize that this is happening, or do you just ignore it and just keep on going? The reason I'm asking this question is we're here, and although this program, it's a cardiac symposium, spirituality has a lot to do with many of the people that go into your offices and through different surgeries. Some of them do not, but many do. Have you found that there is a difference versus not believing versus believing?
The question you're asking?
I guess, let me simplify it. Do you find that spirituality plays a huge part in not only the healing process, but the process that they can get well?
Okay. Does one's religious or spiritual affiliation complement the outcome?
So I think that's a little bit difficult to answer because not everybody feels talking about their spirituality when they come to a surgery. Right. So I think the short answer is absolutely that. When you have faith, you believe in somebody being that controls all, and your faith is placed somewhere outside of what we as humans are able to do, I think it definitely has a huge positive impact. I think when we look at what we do from a purely objective standpoint, we're human beings who are trained to look at data, to learn procedures, to look at outcomes and follow trends. So it's a little bit difficult to answer in that setting. And again, like I said, not everybody is willing to share their faith, their belief, but I think it does.
Okay. Thank you.
I'd like to address. So as I'm the associate clerkship director, so I'm in control of some of the curriculum for the medical students, and I teach medical students at all stages. Part of the first year medical student curriculum is, and it goes throughout their training, is looking at a person as a whole, okay? And asking those questions. How much of their belief system is bounded in faith? And we have to look at different faiths, okay? Some people have many different beliefs that are different from what we understand, and we have to understand and see that person in their context. So new doctors are coming up being trained to look at that and to respect it and to draw that out of a person. And we have chaplaincy on site, and they are also many different, basically they'll handle whatever faith you're in to give you support in that where you need it. Now, I have seen where I've ordered labs on a patient, okay? And I just thought I knew how the lab was gonna come out, right? And I would say to the mother, you know, she'll cry because I have to give her, you know, I try to prepare people when I think it might be bad news. And I say, you know, this is what I'm expecting to come when I order this lab result. And the mother will start to get upset. I'll hold her hand. And I'll say, but you could pray. When the lab result comes back the way we didn't expect it to come, it came back better, she's not gonna thank me, right? She's not gonna believe that I had anything to do with it, right? But we do encourage, because just like the children sang, there is hope, people need hope. Yeah. People need hope.
Okay,
and when you're in a good mental place, that actually boosts your immune system. Yeah. And as doctors, we're very limited in what we can do. We help the body heal itself most of the time. So when you heard I'm talking about collaterals, how it's amazing that the body finds new ways to get blood. It's amazing because it was created to be amazing, okay? And so when you see that in a patient, you want to help that to grow. You don't ignore it.
Thank you so very much. And the question that I'm asking for someone else is this. What are the symptoms of heart?
Can we just pause? I need to.
Of course.
We will take that question later on. I need to handle a couple questions from online before we take that question. Thank you. So there's a question, what's the relationship between the heart and the lung, and what is the premature ventricular contraction?
Well,
what causes it to be a serious condition?
So I think it was mentioned before that the heart is really two separate pumps. So there's one pump that takes the blood returning from the body, and that's the right heart, and that pumps it to the lungs. And then there's another pump that takes the blood returning from the lungs and pumps it out to the body. And this pump has to work in concert for it to work efficiently. And when you have a PVC, or a premature ventricular contraction, the heart isn't working in concert. And so just like if we have singers that aren't singing in concert, the heart, when it's not pumping in concert, it doesn't work very well.
Well done. Well done.
I want to add one quick thing. PVC can be something benign, meaning you had too much coffee that day and the heart's a little bit excitable, but it can be a sign of something more serious. So that's something that definitely would need to be addressed with your
There's a question pertaining to the recent football player that got hit in the chest. And, I'm sorry? Yes. Is there anything one can say about that kind of rhythm issue?
Well, unfortunately, we're not privy to his entire medical history. So, but there are children, young athletes across the country that die every day because they've been hit in the chest at the exact inappropriate time to reset the heart's rhythm. And there's a specific part of the cardiac cycle that if there's enough energy delivered to the chest at that exact moment, it can stop the heart. So this is one of the reasons that, along with CPR that we all advocate, AEDs are another thing that we advocate for the general public to be in places of worship, malls, and sporting events to get the heart back beating.
Thank you so much. So we will limit the audience question to only those who are standing now, in the interest of time.
I understand. So we need to.
All right. Be patient.
Okay.
Have your short question.
It's a very short question. We just want to know, what are the symptoms when the heart begins to fail?
Thank you. That's a good question.
Yeah, it was a good question.
Thank you.
So there are many symptoms. I think I mentioned previously. Some of them are subtle. You start to get tired with things you normally do every day, or you're active sports person. You play tennis or golf, and you just can't do as much as you usually do. Okay, that's one of the first signs. It's exercise intolerance is what we call it. And then if you start to have shortness of breath, when you're trying to, you have to sleep on more pillows. You have shortness of breath with the activities you normally do. That's one of the signs. And then one of the later signs is when you start to have fluid buildup in your legs, your arms. These are, however, later signs. So any one of those things, if you're not feeling right, you really ought to go see a physician.
Thank you so much, Dr. Camacho. We'll take this question.
Hello, good night. My question is, as we age, whether we're hypertensive or not, as part of our healthcare team where preventive medicine is concerned, should a cardiologist be a very integral part of our healthcare prevention team?
Well, I think that as you get older, knowing that cardiac disease is the #1 killer, I don't think it's a bad idea. But what most people have is a primary care physician, and that primary care physician should be able to know when to make that referral to the cardiologist, usually. But I think in general, as you age, especially when you get into your 70s and 80s, you will have a cardiologist involved.
Okay, we will take Fred.
Thanks. So, Dr. Camacho, I am really intrigued with the heart versus a pump based on your presentation. And I can't help but I'm actually leaning toward the pump because so much of what's going on today, we are a battery-operated society in so many cases, our cell phones, cars, and so much more is coming on stream. And it looks like it can give you a more, more balanced life. Seems like you can live a more active, more fulfilling life, as opposed to the continuous taking of medicine and all that kind of stuff. So I just want to know, what's life after either of them? Can you run a marathon or, do things like that?
So you can run a marathon with either one. However, I will tell you that Myra, I showed you, she's got her pump 15 years this April. She doesn't want a transplant, okay, because she's done her homework. What I didn't mention is that transplant patients, the survival at 20 to 25 years is only about 15%. Okay, and with the pump, as long as you can tolerate living with the pump that long, and we see people out 18 years now, it can be changed if it fails. So now immunosuppression can cause renal failure. By the time you're out 10 to 15 years from a heart transplant, at least 10% are on dialysis or had to have a kidney transplant because of the immunosuppression. So that's a very good question.
So it's not a benign thing. Thank you.
Benign to have a
Zoe.
heart
it's
transplant.
Not a nice battery versus medication.
No, actually, when he first asked the question, I just thought he wanted a pump.
Yeah, not a nice battery at all. We will not give you a battery-operated pump. Okay, we have our question.
Yes. My question, someone that has been smoking, give and take, 10 to 15 years, which part of the body is affected first, the lungs or the heart? And can that person be a donor if it should reach to that point with that previous background of smoking?
Oh, you're asking if a person who is a chronic smoker can donate the lung or a heart?
No, which one of the
Which one of the organs go first?
the organ is being affected
Oh,
first,
first, okay.
the lungs or
All
the
right.
heart?
So
We're
a
sort of
smoke.
chatting
can
back
they
here,
be a
we're thinking
donor?
the lungs get affected first.
Okay, thank you.
Okay, but with time, the heart will too.
The heart will be, yeah.
And does it affect a donor? So that's determined at the time of the donation, when they're assessing the donor. We've had donors smoke years, okay, and turns out they weren't smoking that heavily, whatever, and the lungs are still okay to donate.
Okay.
Thank you so much.
Appreciate
We have
it.
this lady.
Good night. I just would like to thank the panel. My grandmother, who is 98 and will be 99 in a couple of months. I just found out that she did heart surgery. They were saying she was strong enough to do it. So I am a bit worried, you know, because she's 99-year-old, almost. So I'm a bit worried, you know, to know what will happen, because at the age of 99 and doing a heart surgery, you know, yeah?
All right, well, that is a very interesting 99.
Uh-huh,
Okay.
almost.
Yeah, so are you asking, the patient had the surgery already?
Yes.
And the patient is doing okay?
Well, not really. She says she's okay, but my uncle is saying something else.
Yeah, so. But the patient said she's okay. But the uncle said that patient is not okay.
What kind of heart surgery did you have?
You know, I didn't ask because yesterday also I went to the heart doctor in Manhattan with my mother.
Yeah.
And they found out that she had a blockage in the artery. So that is when I called my uncle and was saying to him that his sister, you know, have to do surgery. And he said, but my mother just did one 2 weeks ago. So, you know, and another thing I'm so worried about, because my daughter also supposed to do a heart surgery next week, sometime next week.
How old is your daughter?
She is 38.
38.
She's going to be 39 in May.
Okay, all right then. So you're asking the question, what can we do for her?
Not really.
So
I
big
am asking because she was born with a hole in the heart.
Okay.
And I think a year and a half, they did a surgery. And it never affect her. But lately, she was complaining about her heart feeling heavy and stuff. And I tell her to go to see the doctor. Now they say she have a problem. You know, it's just too much. I am so thanking God because, you know, I'm learning, I'm getting the knowledge, you know, because so much heart problem in the family.
Yeah.
So
So I'm gonna go the route. So at 99 years old, 98 years old, having a heart operation. So I'm not quite sure whether she had an open heart operation or whether she had an interventional procedure where they put a stent or a valve through the groin.
Well, I didn't ask him because
Yeah,
it was
that's okay.
already, I'm already going
Yeah.
through too much because I was at in Manhattan for my mother, only to find out she had a blockage.
Yeah, that's okay.
So-
you know, if we're talking open heart operation, it's a big operation, so it takes a lot out of you. Most people after an open heart operation say it takes a good 2-3 months to where you feel back to yourself. So it takes longer to kind of get back on your feet. The fact that she's talking to you and she's telling you how she's feeling is a great sign. That means she did well enough to where she's actually, slowly improving. So that to me is reassuring. Now, as far as your daughter in her 30s, so the hole in the heart can be in different places. Sometimes the interventional cardiologist, not the surgeons, the interventional cardiologist can go inside the blood vessels, inside the heart, and try to patch a hole. Depending on anatomy, depending on location, that may not be feasible, in which case she would need an open heart operation. But again, it all depends on where that hole is, whether it's in the between the upper chambers, between the atria, or between the lower chambers or the ventricles. But for the most part, that operation, people do fine. People do very well.
All right, thank you, thanks.
We'll take yes, please.
Thank you for your time, work, and experience. Being that it is federally Black History Month, but as for us, our Black history, just as any cultural history, is forever. And you had mentioned how this month is Heart Month, Women's Heart Month. So with that connection, and you already mentioned how it's a predominant killer of women and disproportionately Black women, and this country's and many of the world's medical history and developments is at the expense of unethical, violent, forceful experimentation on formerly enslaved Africans in this country. How have you seen and do you know of any genuine investment, research, and data that is qualitative and specific to the health and the different ways that symptoms show up specifically in Black women and Black people and the treatment, as we know Tuskegee experience and the obstetrician developments? And in connection with that question, do you also know of any advanced data and qualitative scientific research and statistics on the generational trauma, broken heart, anxiety, depression influence on heart disease and issues that Black women and Black people face? And lastly, if you want to entertain this last question, I'm in the era of young people. I probably watch too much Netflix on science, but how do you feel about the ethical transformation and societal transformation of the roboticism of the human body with different medical implantations and pieces? Obviously, we need them to survive, but how do you see that evolving? Thank you.
Well, as you want to answer that as a moderator, I think that question is above us in terms of the focused nature of our presentation today. I'm wondering if you and I maybe together and create a forum that could discuss some of those essential ideas that you have. Yeah, we can get together.
Excuse me, what was the focused nature? Is it not for cardiac health and women and a symposium?
Yeah, this is more a general.
It's a general question as well. They don't have to answer it. I mean, I could go apart, but I believe it's still relevant. But thank you.
Okay, does anyone have an answer?
To my sister who said a mouthful up here, that's a very deep question. And as a scientist, what I've noticed, okay, is that when medicine starts to look at specific demographics, it's when they find after they've done the general population, there are outliers. So why is this medication not working? Why, I remember when I had my son, my pressure went high. I never had a blood pressure problem. They're pushing labetalol. okay? When a calcium channel blocker works better in black women. They don't find that out until the outliers start to die. And then they go, what's wrong with our data? Oh, there's another set of people that we never even realized might have different, physiology. And that's when you see more data come out, okay? So when you see stuff that's new, don't expect a lot of black people to be in it. Not right off the bat. It usually trickles on afterwards. That's just my honest opinion from what I've seen from studies that come out. This is why you need, like we say, representation matters. This is why we need places like Meharry, we need places like Howard to do this research right off the bat, okay? And look at our populations. You hear a lot of things now with maternal death after delivery, after bearing children.
Infant
That came
mortality.
out again because outliers are dying. They're not following the normal trajectory. We're looking like a developing country when we're highly industrialized, call ourselves the first world. So it's embarrassment, some of it. Some of it is also a surprise. People didn't think that it would happen, and so they realize it happened. It doesn't just only affect our people. It happens with many different cultures, different races. It's predominantly the majority race, and then afterwards you'll see it later on. Now, when you talk about the second part of your question, I just want to remember.
Like broken heart syndrome. I think it's called cardiac myopathy, Takotsubo or something like that. Takotsubo,
Okay.
thank you.
So I'll let them talk about that because that's a particular thing, but remember what I said about toxic stress, okay? So if you're in a situation where there's no relief from your stress, where you have little hope, that's gonna damage your body. Okay, that stress alone is gonna damage your body. And then we can't expect your body to perform the way other bodies perform, right? And then it turns around and says, oh, well, this set of people, their bodies are ill-equipped for what life is bringing. Well, that's because of the stress that they're under. So there has to be some realization that it's not just inherent in that body, it's what that body's being put under. There's a lot of stresses that we don't see. But I'll let them answer about your specific question.
Yes, and just to specify, is there qualitative data on the generational trauma, stressors, and depression, specifically with Black people, and if not, in general?
I have the data, but I'm assuming it is. I'll tell you that over the years, I've been a physician now for 30 years, and over the years, I would say probably in the last 5 to 8 years, there's been a great emphasis front and center on social determinants of health, okay? And we didn't have enough of it. How are you going to expect someone with insulin-dependent diabetes to get better if they don't have a refrigerator that works in the home? How are they supposed to get what they need if they don't have a job? What about food deserts, right? Areas where there just aren't supermarkets or groceries where you can buy healthy food.
Nutritional value.
All of us, not all of a sudden, but I would say over the last 5 to 10 years, a great amount of government money has been put into this, into figuring out how to get around this issue of social determinants of health. It's extremely important, and it's one of the few ways we're going to be able to level the playing field. And also just people can't even get to the hospital because they don't have means of transportation. And let's say they have some disability where they can't get on a bus. There's a lot to be done. The United States spends 17% of its GDP on healthcare. That's way more than any country in the world. And there are countries that only spend 5 or 6% of their GDP that have better outcomes than the United States in terms of health. And one of the metrics that's looked at by the World Health Organization is maternal and fetal health. Okay, that's one of the very few metrics they look at. And we're not doing well as a country. So there's a lot to be done. But I think the positive thing is that more resources are being put into figuring out how to make this better.
Thank you so much. We will go to someone who has an inside view. Devin?
Two things. Thing one, is your marketing person here?
No.
I think you're a marketing person. I think this is what you guys did today is amazing. And Robert Wood Johnson need to promote that, that you guys were in Brooklyn, not in New Jersey. Yes, Lincoln is important. What you guys did here today is amazing. That's the business end of the business, Lincoln. Sorry. Now, the next thing I have a concern. I'm not sure if you, being an insider, is aware of it, but are you aware that in hospitals with 300 beds or less, that they're closing due to the overwhelming nature of expenses? One of the first things they do is get rid of the cardiothoracic surgeon because it's too much money. And hence, Doc, you talk about access. Someone can't get the bus because they got to go really far. I'm sure, even though I'm not in the Brooklyn region at the moment, I am sure that there are smaller hospitals around that have closed their programs. And so they have to go to the regional or the bigger hospitals. Are you seeing that trend, closure of the cardiothoracic aspect of the business in the smaller hospital, 300 beds and smaller? That's what I'm seeing, and sometimes I help make that decision too.
You're right. I mean, the hospitals are getting pinched, even the bigger hospitals. So the country, I want to say, maybe again, 10 years ago, started moving towards regionalization of care. And that is because of certain reimbursement issues, meaning if you don't meet certain standards, you don't get reimbursed. The hospital, the only ways it could survive was to try to produce excellent care, but as efficiently as possible. And hence the reason for that. So the smaller hospitals that don't come under the umbrella of a large system suffer because they need that infrastructure to stay alive. The expenses are exorbitant to be a standalone hospital. So you're right, but I think it's really, what I hope will come out of this is that we will have more efficient delivery of care and higher quality of care. But you also need safety net hospitals to take care of people in regions that are not close to you. Okay, but I think those hospitals, and I may be wrong about this, but I'm pretty sure I heard that those hospitals are continuing to get supported because they are in areas that are remote, where their services are needed. And then if the patients are complex, they get sent to the regional center.
Thank you, Dr. Camacho.
I will
say?
add
Yes, go ahead.
A little bit. So it depends on how you look at it. That may not be necessarily a bad thing. So again, I'm gonna switch perspectives a little. So on one hand, I think you're thinking, well, if they close down, we don't. But what I want to point out is we're simplifying cardiac in general. In order for a heart operation to happen, you need an extreme amount of resources that comes from people, from the operating room to housekeeping to surgeons to anesthesia to perfusion to nurses in the intensive care unit to nurses in the recovery unit to nurses in the preoperative area. So there's like massive amount of infrastructure that you need in order for an operation to even take place. And then post-operatively, you need massive amount of resources to actually take care of the patient to the point where they do well and they go home. So if you have 20 hospitals in a small area, it's just not feasible to have all those resources at every single hospital. So I think it's okay to have that specialized care regionalized as long as there's the appropriate care at every single hospital. So having the primary care physician, having the cardiologist, having the interventional cardiologist, and having the people who are knowledgeable enough to recognize what the problem is, take care of it, and then if you need to, transfer you to the center that has the higher level.
Our last question is, someone had a young person had a ruptured aortic aneurysm.
The young man, his name is Grant Wall. While covering the 2022 FIFA World Cup, he died suddenly at age 49, and it turned out he died from a ruptured aortic aneurysm. My question is, could there have been symptoms that he might have been missing, or symptoms that are so subtle that he may not have, his body was possibly sending out signals to him that he might have missed before he had a chance to seek help?
Well, okay. Number one is high blood pressure. Okay, so if he had high blood pressure, or it wasn't, maybe he didn't know, that's the one, and that's the reason for having a primary care physician and getting checked up. But that most likely his blood pressure was just off the wall, and that's what happened. I don't know if there are any other major.
Yeah, so unless you have high blood pressure that is controlled, some of these things are related to like a genetic mutation that makes the tissues be a little bit thinner, so they tend to stretch out over time. So unfortunately, this happens in the younger patients, and unless you go to the hospital for a different reason and they incidentally notice that the aorta is dilated, there's no specific test for it. So usually this is caught either because you have high blood pressure, or you have other symptoms and they do all the studies and they pick it up, or it's just another CT scan for whatever other reason. And it's one of those things that I mentioned. When the aorta dilates, if you pick it up early on, you can follow it, and once it gets to a certain size, then you can intervene to prevent that rupture from happening.
Thank you so much. We'll hear from Jordan Ferdanki.
Good evening, everyone. A great privilege has been afforded to me by the Hanson Place Seventh-day Adventist Church and by the Men's and Health Ministry departments. So I would just like to say a big thank you to all the individuals who united here today to create this program and to have it become such a tremendous success as it is today. So first to Dr. Lincoln Blackwood, he was approached by the Men's Ministry department. He didn't hesitate at all. He set his best foot forward. He used all of his abilities to their fullest, and he decided to exceed the expectations today. So, round of applause for him. I'd like to thank the communications team all up there with the audio control. Thank you for persevering through all the issues that happened this morning and during this program. I'd like to thank the Altino brothers for the music that they played, the Hanson Place Men's Chorale, God's Instruments, and Charissa Williams. I would also like to thank our visitors, our community, and our members for attending in person and online. But now I have intentionally saved the best for last. Please give it up for our robust lineup of medical heroes. Not only did they come from New Jersey, but we also have our very own Ella Jean Richards-Francois, who came from Downstate Medical Center in Brooklyn. I'd like to thank you for enriching us with wisdom and knowledge to have fuller and better lives. And if I may speak on behalf of all the youth here today, including myself, you have enlightened us. You might have even strengthened the aspiration of several youth here today who decided to venture into a career of medicine, including yours truly, of course, but we'll skip past that part. So thank you very much for coming. We appreciate your support, we appreciate the information you gave us, and may God bless you.
Okay, before you go, to all our viewers online, I want to say thank you for tuning in. And I know that there's some looking in from Jamaica. Oh yes, of course. And just want to say thank you so much. Want to thank members from the Ruth's House of Prayer. They sent a contingency. Please stand up. Actually, the leader of their church is one of our nurse managers, at Robert Wood, the Cooperman Barnabas Medical Center. Pearl. Where's Jay? Jay is my right hand. And good to see you. It's one of my skilled colleagues. And Shirley, his wife. Please stand up. Yeah. We had all other representatives from the hospital who left because of other business venture. Just want to say thanks to all of you who share this moment with us. And Pastor, could you just say a benediction for us before we, I'm sorry? Pastor Langley? You want to give us our closing prayer? There's a mic right there, yes.
Thank you so much. Loving Father, what a day this has been. And as we are about to separate from one another, may we hold dearly to our hearts the informations that we have gotten. Now may the Lord watch between each of us as we will separate from one another, but never from you. Thank you for holding us all dear to your heart. In the name of Jesus, our Lord and Savior, we pray. Amen.
Thank you all, and good night. Music. Thank you so much. Thank you so much.